Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an educational grant from Janssen Pharmaceuticals, Inc., administered by Janssen Scientific Affairs, LLC.
I'm Michael Face. I'll be your moderator today for this Medscape live event entitled New and Emerging Adjunctive Treatments for Major Depressive Disorder. I'm a professor of psychiatry here in Philadelphia at the University of Pennsylvania, and where I'm also a researcher at the Corporal Michael J. Crisant's Veterans Affairs Medical Center. And I have the privilege today to be joined by two wonderful colleagues in primary care. First, Paul DeGramji. Paul's a family physician at the Collegeville Family Practice and also a member of the teaching faculty of Ursinus College. And then second, Charles Vega. And Charles is on the other coast, and he's at UC Irvine Department of Family Medicine, where he directs the program.
Thank you, Michael. So, folks, we're going to talk about, as the name implies in this whole discussion, about depression therapy and having some residual symptoms. So look at some of the data of what we've been experiencing with our patients over the last 40 years. And as the topic says, antidepressant efficacy has not improved over the past 40 years. If you look at the studies there in green, those are antidepressant, and in gray, they are placebo. In 1980 to 89, 1990 to 99, take a look at the response rates. It's around 50%. Response, by the way, meaning that you're getting 50% or more improvement in the MADRS score. So that's occurring 50% of the time or so. And this is the best that we've done with really all medications. None of the medicines, the 20 or 30 antidepressants that we have, none of them have claimed any superiority over any of the other ones. They all have a relatively, I would say, low response rate, which at 50%. The remission rates are much worse, and we're going to show you that as well. But the response rates have been relatively low. So this is what's been going on over the last several years. And, patients, they oftentimes will come in and they will have complaints about this. We will have in ourselves internally some complaints about this and thinking, is this the best that I can do? What more can I do? We had the STAR-D trial that was about 19 years ago, maybe giving us some indication as to what we could do about changing or augmenting medication. But again, our response and remission rates were pretty low. Now, one of the things that we do in our practice is doing PHQ-9 on our patients. The PHQ-9 is a very, very valuable tool, the Patient Health Questionnaire, which mirrors the DSM categorization or diagnosis of depression, major depressive disorder. When patients come in and we suspect that they may have depression, we're going to screen for them. We ask them these questions, whether they have any of the following going on, none at all in the last several weeks, the last 2 weeks, several days, more than half the days, or nearly every day of little interest or pleasure in doing things, feeling down, depressed, or hopeless, trouble falling asleep or sleeping too much, feeling tired or having little energy, poor appetite or overeating, feeling bad about yourself, so a pessimism kind of a thing, lack of concentration or concentration troubles, or moving so slowly or moving so fast that it got you in trouble or others remarked about it, and finally thoughts about death and dying. And we rate these patients. In my medical records, this is actually built in there. And we do the scales on everybody that comes in that we are suspicious of or that we're following for behavioral health issues. My medical assistant actually does it before I get in the room. And when the scores are 0 to 4, we say not much is going on, maybe minimal depression. 5 to 9 is mild depression. Watch these patients carefully, maybe bring them in at a short time in the future. 10 to 14, we're dealing with moderate depression where intervention with either psychotherapy or medication or both is indicated. 15 to 19 is moderate to severe depression. These are patients where you really have to sink in and do what you need to do to help them with MDD. And 20 to 27, sometimes in these patients, you have to even get some help. So these are some of the ways of gauging the level of depression in our patients. Very important to do initially and as you follow your patients just to see how much improvement that they're going through now. Look at what the title of this slide says, inadequate symptom improvement. That's what's going on in our experience with our patients that we're treating for depression. Remission, I said this earlier, let's take a look. Remission, which is defined by the MADRS score of scores less than 10. Okay, if we're using the MADRS score, which we do in clinical trials, a remission is occurring in numbers below 10. Now, remission occurs in only 20 to 30% of patients with each treatment trial. The STAR-D trial showed us that specifically, that even though we're doing so with our patients to get response, about 50% get response, only 1 out of 5 or 1 out of 3 will actually have remission. Again, remission defined as basically being back to normal. But take a look at the middle category here. Even with remission, patients can still have some residual symptoms, okay? So we'd like to say that remission is having no symptoms whatsoever, but in a lot of patients, when you score them with the MADRS and they score less than 10, some of them still do have some symptoms like low mood, anxiety, irritability, guilt, and lack of interest, work impairment, insomnia. One of the most common residual symptoms of treatment that we give to our patients is insomnia. And finally, cognitive impairment with some memory, trouble thinking, trouble getting things done with your mind, recollection. So what's the issue with inadequate symptom improvement? When patients are only in partial response, when they are only in partial response or even in remission where they have residual symptoms, take a look at some of the problems that can happen. Increased risk of relapse or recurrence, increased chronic depressive episodes, decreased duration between these episodes of depression, decreased quality of life, impairments in work and relationship, increased morbidity or mortality, and in fact, these patients may have a higher rates of suicidality. And following these patients very carefully becomes so important. So our goal not only is to catch patients that are experiencing MDD as early as possible, so we can get them to remission and get them to the best response that we can get, but also try to get them from response to remission with less residual symptoms. These are the keys in identifying and managing patients with MDD. Now, some of the residual symptoms of MDD are looked upon differently with what patients say versus what clinicians say. Patients will report their residual symptoms as being weight gain, sleep disturbances, low mood, decreased concentration, and decreased energy. These are some of the things that they complain about. Interestingly, what clinicians note, and to them it becomes important, is also sleep disturbances. So for both patient and clinician, sleep disturbances are critically important. And identifying this and managing this becomes very heightened in our level of responsibility. But also with clinician related, there's anxiety, somatic symptoms, physical symptoms, headache, abdominal pain, weight gain, GI complaints, urinary complaints, low mood, feelings of guilt. And these are some of the things that clinicians complain about. So a little bit of a difference between what patients feel and what clinicians feel, but nonetheless, both know that with treatment of MDD, we're not getting our patients too often to response and remission.
Wow, that was a great summary, Paul, kind of discussing it from the screening aspect, because USPSTF does recommend we screen all adults for depression, right through treatment, but then very importantly after treatment. You can't just set it and forget it. Just because patients are doing better on whatever measurement you might be using, usually not the MADRS in a clinical setting, but I use the PHQ-9 all the time for screening, and helps in diagnosis and in treatment follow-up. And many patients aren't getting there, and they are having residual symptoms. In this sample of 108 patients who did achieve a good response to therapy, you can see that actually about 20% or so had at least 4 residual symptoms related to depression, a lot of which you just described to us right now. So I think it's really important to follow patients, and then ongoing. Depression is not a static illness. As folks develop new symptoms and or maybe some of the old symptoms that they had associated with depression are accentuated as they go through treatment and feel better, we want to go and treat those. And that begins right away. So this is a cohort I was interested in because these are folks who did well. They're part of that 50% who experienced a significant response to therapy, and so then they were followed afterwards for residual symptoms. And this study was actually looking at sex as a differentiator of those residual symptoms. So somatic symptoms in particular were really common here. These are aches and pains, headache, fatigue, things like that. And of course, as I think you already alluded to, Paul, there was a connection between residual symptoms and quality of life. So this was impactful on patients' lives. And it was interesting that there was a difference based on sex, that women were more likely to complain of some kind of abdominal, or in their terms in the study, stomach pain as a general term for patients to understand. And men were more likely to experience insomnia. So I thought this was interesting in that you could see these residual symptoms. They are somatic in nature in many patients, and you can pick them up right away within a couple months. And now we're going to listen to a patient story, Natalie, as she talks about her journey through treatment for depression and some of the additional symptoms she experienced even when she started feeling better.
I first remember the feeling of like depression or depression-like feelings in maybe like preteen, beginning of teen years. And it definitely has ebbed and flowed depending on circumstances. But in the last year, it's been especially severe, kind of in tandem with a difficult breakup. When I'm not feeling well, my sleep is always a big one. I have trouble falling asleep and then trouble waking up. Definitely low energy, constantly feeling drained and exhausted, more distracted. So what the not feeling functional look for me is I have a lot of decision fatigue. So I can kind of like rally for work for the most part, but then in my personal life, really having trouble making decisions. Feeling very self-conscious about being perceived as like a downer or always not doing well. So tending to withdraw or feeling anxious about interpersonal relationships. The most common side effects I have are nausea and GI upset. So for most meds that I've tried, I've just had like really overwhelming nausea and then exhaustion. So just like very high levels of fatigue. And then when I've tapered off or stopped abruptly, very severe like dizziness and GI upset. What makes a good clinician for me is someone who really hears feedback about side effects and takes them seriously. So doesn't just kind of check them off as something on a med label, but has that understanding the impact the side effects have. It might feel fatalistic in my head that side effects felt terrible forever, but in reality, maybe it's 2 weeks. And I think a clinician who can take the lead and kind of staying on top of the timeline and taking that burden off of the patient would make them very valuable.
So a huge amount of gratitude to Natalie for sharing such a personal story and doing it so eloquently. And she's really, had some insight into some wonderful things here. And I think it just calls out to me the need to continue to follow up in primary care, not just for her mood symptoms, but also for those somatic complaints, partly because, if somebody starts having stomach pain, could you develop biliary colic or, severe gastritis with a duodenal ulcer? Absolutely. These things happen. And so we want to make sure we follow our patients and just be good clinicians and thinking broadly about their differential diagnosis. But many times it does come back to that mood disorder, which is a risk factor for a lot of these symptoms. Michael, do you have any other comments on Natalie's great commentary?
Right about the importance of her somatic symptoms, and I would think maintaining the current antidepressant, which was somewhat helpful, and trying to help her with her residual both anxiety and somatic symptoms with an additive second medication. And so I might think of mirtazapine or even quetiapine, but although we'd have to have a further talk about that as the two leading adjunctive strategies in this particular circumstance. So there are times that you conserve the gains that you've gotten, and if the antidepressant's well enough tolerated, then go with a targeted adjunctive therapy that could help.
What a beautiful segue. Thank you so much. That was really helpful because that's exactly what we're going to talk about. One thing about when I'm introducing, traditionally it's called an antipsychotic drug. I don't say antipsychotic. I call it a dopamine antagonist, which I know is a simplification of its MOA, but still it's better than patients saying, wait a minute, are you saying I'm psychotic? And then just going down that rabbit hole. And so I instruct patients that these drugs were originally designed and, oftentimes used for thought disorders, but now they're used primarily especially in my practice, adjunctively to treat depression. And there are other choices as well. And I think it's very important to note that there's a lot of medications coming down the pipeline that have different mechanisms of action because there are different ways. And I think that will, when we think back to Paul's side about how we haven't done that well in terms of really improving depression care over time and achieving remission, these different agents will help folks to get there. So you can see that there's looking at melatonin, looking back at different serotonin receptors, even a thyroid hormone receptor agonist, which is just really interesting because that's something that was commonly done in the past as well, was low doses of levothyroxine. If you can do so in a safe way that doesn't necessarily affect patients' metabolism, these could be really important gains. And we're going to spend a little extra time, and Michael's going to go through seltorexant, which is an orexin 2 receptor antagonist. We were familiar with that class already, a lot of us, and another one that really hits now multiple receptors called lumateperone. So please take it away, Michael.
Thanks, Charles. I think that when you're looking for an adjunctive therapy, you first of all are concluding that the patient has responded somewhat to the first medicine and that it's well enough tolerated to continue as the platform for the second medication. And among that list of residual symptoms, you saw both patients and clinicians valued insomnia as a really important target. And insomnia is a general severity marker. It is associated with risk of suicidality and are safer, easier to use newer generation antidepressants are generally not particularly good at reversing insomnia. And that's one of the reasons why it's such a common residual feature. So seltorexant is a selective orexin 2 antagonist, meaning it's a little different than the currently approved orexin antagonists that are already around for the management of insomnia. And in its development, some animal data suggested that it could have depression reversing effects in animal models of depression. And I think importantly, we needed to get the dose right, and several small studies had to be done in order to identify the most effective dose. And we're looking at doses of at least 20 and possibly occasionally 40, but I think only 40 for somebody who didn't respond to 20 looks like the most effective antidepressant dose. Now, here you see one of the phase 2 studies in which the 20 milligram dose was the only one that separated fairly dramatically. And now we're into a different analysis of the time to benefit. And here we are looking at side-by-side benefits over time. And again, you see separation with the 20 milligram dose looking more likely to be the better dose. And so these data were positive enough to bring seltorexant on into phase 3. And we now have some studies reading out in phase 3 that suggest that indeed it looks like the 20 milligram dose is the sweet spot. And there should be sufficient data for an application to the FDA within the next year or two. We're hoping here for that. So we may have our first adjunctive therapy that specifically targets insomnia as well as residual depression. Um, I think importantly, seltorexant's really well tolerated with a very low risk of dropouts due to intolerable adverse events. Now, you may know lumateperone already if you treat people with schizophrenia or with bipolar disorder. It is approved both for antipsychotic therapy as well as a monotherapy and adjunctive therapy for people with bipolar 1 or bipolar 2 depression. As you can see, it is an interesting and complex molecule, and it has at least 2, if not 4, relevant targets. Like other newer generation antipsychotics, it's a serotonin 2 antagonist and a dopamine 2 antagonist, but it may have some partial agonist effects at lower doses on dopamine 2, meaning that at the beginning doses, it may actually have a potentiating effect here, not an antagonistic effect. And compared to other antipsychotic medications, this has some activity on the glutamate system, and making it a possible distinguishing characteristic from some of the other newer generation antipsychotics that we treat our patients with. We know it treats bipolar depression effectively. It's already been FDA approved for that. And now here you see the first of the phase 3 studies as an adjunctive therapy for people who are taking antidepressants that were somewhat helpful, that they could tolerate, and then this medication is added. It appears to be most effective at the 40 milligram dose. There may be some patients who can benefit at the 20 milligram dose, but we generally use the smaller dose to initiate treatment in patients with a history of medication sensitivity, or to back down in patients who may have too many of the potential side effects. So I think importantly, it's got, as medications called antipsychotics go, it's got a fairly good tolerability profile. The most common side effects are dry mouth, fatigue, tremor. I see a little more dizziness than I see with some other newer generation antipsychotics. Importantly, this is a medication that does not have many people experiencing sleepiness and has not been associated in clinical trials with weight gain in both short term and in studies of schizophrenia and bipolar disorder long term. Along with that comes a low, even for an atypical or a newer generation antipsychotic, a low risk of extrapyramidal symptoms or the metabolic consequences of weight gain and other cardiometabolic side effects. And here we go back to the phase 3 data, and you can see a really nice separation starting to show significance within the first 2 weeks of treatment. And again, you're adding a medicine to an ongoing antidepressant, and you're seeing a meaningful number of patients feeling better in terms of symptom reduction in 1 to 2 weeks, and in terms of overall global profile in 2 to 3 weeks. So we've got a good rapid profile with a good safety index. Again, well tolerated, no meaningful impact on weight or body mass, and minimal incidence of extrapyramidal symptoms. So a relatively atypical antipsychotic. So not all promising new medicines have had happy endings. There was some attempt to make oral alternatives to the exciting, rapid antidepressant effects that have been observed with ketamine. S-methadone was one of the most vigorously studied here, and unfortunately, just not enough people benefit from this treatment to reach the level of significant effects that are necessary to bring a drug to market. So we may not have heard the end of trying to find oral alternatives to ketamine, but sadly, S-methadone is not going to be one of those. You may also know some of the long history of use of opiate agonists as putative antidepressants if only you could control or minimize the habit-forming properties and the tendency for intoxication. And there is a pathway here that has been fairly heftily studied now involving capiate receptor opiate antagonists. But unfortunately, the two leading compounds in this area, aticaprant and navacaprant, have just this calendar year been determined to have not succeeded in their phase 3 studies. So we're still looking for a safe, tolerable medication that works through the opiate pathway. But we're not there yet. So I'll ask the panel to help me out with the remainder of our time and just talk about what you see in your practice. How might having seltorexant and lumateperone around help you in your everyday practice?
Well, I can get started, and if that's okay, because there was a question that came in about should you think about using an augmentation strategy, maybe with lumateperone or seltorexant, or another one of those many agents that there are possibilities, versus using talk therapy, cognitive behavioral therapy, the most common thing, and is there one better than the other? In my practice, not necessarily, but I do try to. But I also think that pushing forward on multiple levers is not a bad idea. If they have specific symptoms like insomnia, difficulty concentrating, then that might be something where I think that maybe a specific medication might be good. If it's more general malaise, and one of the most common symptoms is continued low mood, that's where adding CBT might be more helpful. And it has a lot to do with my patients' preferences. Some of them absolutely want to maintain that medication at a minimum. I feel like I've gotten better. I don't want to add more drugs because then I'm going to be at risk for more side effects. Talk therapy, definitely for them, and other patients who absolutely don't want to do talk therapy. So those choices are clear to me. But I'd love to hear other opinions.
To me, treating major depressive disorder is, for most people, a two medication thing. And I think that patients need to understand that in the same way that they understand that most patients with hypertension need two medications, patients with diabetes need two medications, patients with cholesterol often need two medications. So it's not unusual. So I tell my patients that I'm hopefully going to get you to remission with this one medicine, but don't be surprised if I only get you halfway there. And then the rest of it, I have to help you get to remission, which I tell them is getting you to a place where you were before, where you felt perfectly fine. Now, to do so, I have a particular interest in thinking that if they have a sleep problem, tackling that sleep problem becomes critically important. The better people sleep, the better they do. And we know that in many conditions, not just in depression, whether it's in pain, whether it's in weight gain, whether it's in blood pressure, whether it's even in diabetes, when they sleep well, better things happen to them. So if I see residual of insomnia or sleep disorders, I'm very quick to make sure that I do something to remedy that. And if we now have a medication that's an orexin receptor antagonist that can help us do that for the residual symptoms of depression, specifically insomnia, that's very promising to me.
Thank you. Thank you, Charles. Paul, thank you as well for joining us today. And I want to thank everybody.
Take care.